Thank you very much. And I've actually really enjoyed all the talks this morning, and a lot of what I'm going to say sort of will duplicate what's already been said, really, about the role of opportunity with biomarkers. And these are my declarations of interest. So as we've heard, the treatment landscape for psoriasis has dramatically changed from, efforts to cycle through therapies to avoid toxicity to really where over 2/3 of people who are given novel targeted therapies are clear or nearly clear, and with almost trivial or no adverse problems in the vast majority of patients. So we've got incredibly effective treatment, and across the populations who've got access to these treatments, the healthcare delivery for people with psoriasis dramatically changed. So in the UK, there's been a 90% reduction in hospital admissions, which has been driven by the therapy revolution. But with this, of course, flags up problems. The first is, and pertinent to Chris's challenge that everybody should go on a biologic, is that even now, only a fraction of those who would benefit actually are on biologics. So in the UK, and this is from a data of 17 million patients in England, where we estimated the number of people on biologics, 0.7% of the UK, of the English population are on a biologic. And with this growing population of people who do access the drug, our current paradigm is that they remain on the drug. And I know we've talked about stopping and whether patients aren't too fussed, but healthcare costs and healthcare delivery definitely mitigate against ongoing therapy. And as Chris has indicated, our current treatment paradigm is reactive and not proactive. And this brings problems not only with a lifetime of avoidable disease burden, and as Chris said, if we made the diagnosis, we do have very good treatments, and so early intervention is essential. But even if, as we've heard today, maybe there's an opportunity to actually modify the disease and prevent comorbidities. And so biomarkers do offer, a really sweet spot here to change how we approach therapy. And of course, biomarkers might be designed to track disease susceptibility. But for me, many, or maybe the most people with psoriasis have very mild disease, and you risk converting a population to a worried well if you identify those at risk potentially. However, I personally feel the real opportunity, and it's come out with the talks today, I think, is in prognostic biomarkers. In other words, identifying those subsets of the psoriasis population at risk of more severe disease and or prevention and or comorbidities, with the opportunity of disease modification and prevention of comorbidities. And as Andy said earlier, maybe we don't need predictive biomarkers that will predict drug response, but perhaps we need biomarkers in terms of precision medicine and therapeutics around identifying those people who are in true disease remission, in whom we could actually stop the drug that's being effective. And so where are we with biomarkers? So Chris, actually, I'm not going to run through a whole load of biomarkers because we don't have any. We don't have any well-validated, accurate biomarkers. But as you can see, this is the FDA definition of a biomarker, and they range across a whole range of different biomarker types. But most of the research, rightly, is focused on those derived from understanding the underpinning molecular mechanisms driving the outcomes of interest, because these become perfect biomarkers. If you have biomarkers that are on the causal pathway, they're much more likely to be accurate in prediction, whereas those that aren't are so-called imperfect because they're going to be influenced by multiple factors over and above those that you're interested in. And so, as some of you will have already heard me speak, the IPC partnered with this European consortium that I'm involved in called BioMap, which main effort is to identify biomarkers in psoriasis and atopic dermatitis. And as part of this effort, we did a kind of scoping review to understand the research landscape. And I'm not going to go through all the details now because this is all published with a lot of online information. It's essentially a resource for the research community. But there are a few points to make. One, there's a huge number of biomarkers in terms of disease progression that have been identified. They range across a whole different range of biomarker types. The outcomes of interest that researchers have focused on do relate to those that we've been talking about this morning. In other words, those that predict disease, more severe disease, those that predict psoriatic arthritis or the metabolic comorbidity burden in psoriasis. But the other sort of key factor, and if you think of the biomarker pipeline from discovery through to clinical utility, is that most of the research is in the so-called discovery phase. And the literature reflects the progression in research capacity, really, with early studies being very candidate biomarker driven. So whereas increasingly, and as Kevin discussed earlier today, a sort of hypothesis of multimodal data types going in to try and identify endotypes that relate to outcomes of interest. But the other sort of key aspects of this review illustrated a few points that have also come out this morning that we as a community, and maybe the IPC specifically, could think about. So one is a lot of the studies are cross-sectional in design, and there is a huge opportunity. We have these amazing data-rich disease registries across many countries, many related also with aligned bioresources that could be used to, could be interrogated to better identify in better study design biomarkers. And the other key thing, which was brought up actually in the very first talk, about the variation in definition of outcomes. And so again, as a community, what outcomes really are we prioritizing as being critical to try and identify predictors of? By getting a consensus across our community, it would really perhaps rationalize and focus research effort. I mean, COVID was a wonderful example how when you get everybody going after the same thing, you become incredibly efficient and effective. And so, for example, what do we actually mean by disease severity at a point in time? Accumulative disease severity, development of disease at high need sites. The IPC's definition is need for systemic therapy. So these are opportunities really for us to try and expedite the biomarker discovery. And it also illustrates the importance of interdisciplinary collaboration at scale to expedite the discovery and validation. And there are many efforts now across Europe and in the States where people are coming together with industry, clinical, patients, tech, and regulatory authorities to try and expedite the biomarker pipeline and move it from the discovery phase through to clinical validation. And this is the one that I'm involved in, Biomap, and what we're doing here is curating and harmonizing all the multiple data sets from population-based through to deeply phenotyped multi-omic data sets. And for example, the UK Bad Beer Registry is involved in that. The Danish registry is involved. We've developed a kind of common language across these data sets so we can make sure that scientists are talking to clinicians. So this is obviously a work in progress, but I feel sort of optimistic that it will be at least give us a chance, and we're collaborating with other consortia as well to minimize research redundancy. But I think there are reasons to feel that we've got a good chance. And as Chris said, the old literature is very interesting to go back to. So this is a paper that was published in 1978, which indicated, first of all, had this idea of different trajectories within psoriasis. And actually, in contrast to maybe atopic dermatitis, we may know relatively little about the natural history of psoriasis and the different trajectories. But here, this was a study in the Danish population indicating different subtype trajectories of disease in relation to severity, and showed very strong concordance between in the monozygotic twins, suggesting that there is a strong genetic component to disease prognosis. And this came out as well. There were a number of genetic markers in the scoping review, which we tried to whittle down a bit based on a number of parameters. And not surprisingly, HLA-C0602 came out. And of course, we're all familiar with HLA-C0602 as a potential population stratifier. It associates with a particular clinical phenotype, but maybe it is indicating a kind of endotype that might be relevant to disease prognosis. And it does seem, and I know Jonathan is talking a bit about this, or more about this a bit later on, but it seems to associate with a more obese phenotype, HLA-C0602 negative status, and not surprisingly, a more cardiometabolic complications. So finally, I just wanted to come up with the clinical utility component. And I mean, Chris talked about the importance of diagnosis and a clinical diagnosis. And I think it is important to go back to basics in terms of what if we have this perfect biomarker, what are we expecting and needing it to be doing? So first of all, it needs to change how we think or manage about the disease. It needs to have an impact on patient outcomes. So it needs to be cost effective. So in terms of cost effectiveness, even if you had a perfect predictor, methotrexate, it's still much cheaper, even though we know only 30% will achieve clear or nearly clear on methotrexate. From a health economic point of view, it's still cheaper to give that drug for 6 months than start with a biologic. So we must consider the cost effectiveness. And when we asked across the Biomap consortium, what did the community feel was most important? Cost effectiveness of your biomarker was put right at the bottom of the list. And I think that's probably not in the right place. It's got to be cost effective. And then the other thing is the societal impact. As I mentioned before, the risk of any biomarker, it's got to be incredibly accurate to avoid a negative unintended consequence. So for example, identifying a population at risk of psoriasis, unless it's incredibly accurate or unless it's associated with more severe disease, you're going to convert a lot of people of worried, well individuals. So the societal impact of your biomarker needs to be taken into account. And I think that although I know in the US, no one does therapeutic drug monitoring, it's popular in bits of the UK and in parts of Europe, not generally. And I think it tells us some lessons, illustrates this. So we know, and it's well evidenced, that there is a strong relationship between drug levels and outcome. We know that, and it's best evidenced with the TNF antagonist, but a drug level predicts disease severity 6 months hence. So it's actually predictive. And we also know that it is generalizable to other monoclonal antibodies. And yet it is not used despite, and it may also relate to your chance of identifying people who can actually stop drug. And I thought the discussion around risankizumab was very interesting because I do think it's probably related to drug exposure as well. So in this guide study showing long remission rates following stopping drug. But if you look at the PK/PD modeling for risankizumab, chances of PASI 90 at week 52 are related to your drug exposure. So you could well imagine that drug levels might also be useful to know those people who could minimize their dose or even stop it. And there's even RCT evidence that proactive therapeutic drug monitoring it increases the risk of disease maintenance, and yet it isn't widely accepted. And Joe Lambert, who's led on a lot of this work, indicates from this consensus work in Belgium, where actually TDM is quite commonly used, that most dermatologists felt there was a need for communication around availability, utility, and implementation. So there's a lot of nuts and bolts about bringing your biomarker into clinical practice. On the positive note, actually there are huge national efforts across the world to create the necessary infrastructure for these introduction of these kind of multimodal genomic-based medicine. So I think that there's reasons to be optimistic, and alongside that, the necessary recommendations and so on, and actually the underpinning evidence around biomarkers needs to be adapted from the evidence that's related to, say, bringing a new drug to market, because it's simply not viable to be doing randomized controlled trials for every biomarker. So these sort of initiatives around bringing recommendations in and is a very positive thing. So I think there might be some interesting discussion, but I think on a positive note, it's encouraging that the focus of research effort is around prognostic biomarkers in psoriasis. There are indications that the communities that need to are really coming together in order to progress through that biomarker pipeline, because the disciplines that are required are very different, from basic scientists, clinicians, through to the tech of bringing the biomarker and ensuring it's cost effective and clinically useful. And I do think there are lessons from the TDM story, but I also feel there are lots of reasons to be optimistic. And these are just to acknowledge all of the people that that we work with here and have worked in the biomarker work that I've been involved in. So thank you very much.
That was a terrific presentation, Catherine. I hope you could hear us okay. And I want to congratulate you on your excellent realistic Zoom background, because we know it's happy hour time in UK. You're at the pub, enjoying yourself, and feel free to have a beer while we're having this discussion. So I'm going to take advantage of being the moderator, ask a couple of provocative questions to start, and maybe I'll ask Chris and then Catherine to chime in. So my first question is, when does psoriasis actually start? And the context I want you to think about this in is, if it's a genetic disease, does it actually start in utero or at birth? Or is there actually a prodrome? You were presenting that data, Chris, from CPRD, where one interpretation that there's misdiagnoses of what was actually psoriasis. Another interpretation may be that there's a prodrome, that you have different other skin findings before we see what is considered to be classic psoriasis. So when does the disease actually start?
Well, I guess you can think about the disease starting either clinically, or it's going to be subclinical, preclinical. And I think what we really want is to try and identify it preclinically before it actually manifests as any form of skin disease. And that's where I think that, under some biomarker that might be useful, I think it's going to be a combination of factors, but there's going to be families where there's going to be a high risk of them developing psoriasis, as we saw with those monozygotic twin data from Denmark. And that if there was a way of identifying them early on, where there's going to be already maybe some immunological changes, you can actually get in there early and prevent it then translating into clinical signs. But you're right. Also, I mean, guttate psoriasis comes on very quickly. It's part of the chronic. It's very similar to chronic plaque, but it's not. But chronic plaque psoriasis can come on quite slowly, as we saw in that GP studies. A bit of dry skin, a bit of itching, and it's gradually starting to manifest maybe a bit of dandruff. And that's a discussion as to whether dandruff itself is actually a very mild form of psoriasis, which means those patients may be at higher risk. Because often when you start to talk to patients in great detail, they say, yeah, I've had some dandruff for many years, but nothing much. And then suddenly they got the classic psoriasis.
Or you hear about children who had cradle cap, and then they go on to have these problems.
Because scalp psoriasis is, I think a lot of people, I'd be interested when people in the room think about this, does seem to be a marker of more severe outcome, actually.
Yeah, and about what's shown actually, Mona's really pioneering work of truly early onset disease, where they captured it fairly early, and people with scalp disease were more likely to go on to develop more severe disease over time. Catherine, do you want to share a perspective? When does psoriasis actually begin?
Well, I'd agree with Chris, but in what you said, I mean, I suppose it depends on why you're asking the question, Joel, because it goes back to my point is that why might we need to define what the disease is and what's the impact? In other words, if we're saying we're going to disease modify, we want to disease modify, would we want to disease modify the disease in everyone with psoriasis or in those at-risk population? Because we may be over-treating large swathes of the community. So I guess I'm interested in the reasons for asking the question, because that might flavor the answer.
Yeah, I think it gets at how little we really understand about the natural history of this disease. And and Chris showed some data about, well, it doesn't seem to matter if you're a super responder or not a super responder for how long you had the disease, but we may not be measuring it very effectively, right? I mean, because these people, both groups already have long-standing disease, so it's probably too late. The cat might have been out of the immunological bag, so to speak.
I think you're right, Joel. I mean, there is really, as I said, there's so little really high quality epidemiological evidence about the natural history of psoriasis. So even in, I mean, the UK has got these databases, but actually the long-term follow-up for one patient is actually relatively a short time. I mean, the Danish registry is, the Danish population-based data is really rich there in terms of understanding. And
of course, when patients actually present to us may have been a good deal after when they first started knowing any signs of their disease. Let's go to the audience. Bring in a question. I see Andy has a microphone.
I want to introduce another twist into this and get Chris and Catherine's view on this, and that is lives of the lesions themselves. So the number of TRMs has been associated with severity of disease. So quote unquote, more severe disease, more TRMs. But a clinical observation I think that everybody would agree with is when you have super thick plaques, it doesn't matter how many you have, it's hard to get rid of that psoriasis versus thin plaque psoriasis or lesions that are not as mature. And I'm thinking of some of the knockout patients we have. We have one guy, 30-something PASI. So why, very high PASI, but he cleared very quickly because his plaques were more thin but widespread. And then we have others that have lower PASIs but super thick lesions. And so I'm instead of just disease duration, maybe we should be talking about disease duration and sort of the thickness of the plaques or the robustness of the individual plaques as a marker for clearance or not clearance.
I want to chime in quickly. That's Chris. Jerry Kruger, I think, was one of the people who early explained and documented sort of clinical difference between thin patch psoriasis, thin plaque psoriasis, and thick plaque psoriasis. And being a young person in the field, I'm like, that's nonsense with the statistics. I was not very impressed. And then sticking around for a while, I'm like, actually, he's right. Like, at least in my experience, the thin patch people tend to do worse. They tend to be harder to clear. And I think that's what he had found. So, Chris, you want to share your perspective?
I was going to mention exactly the same piece of work from Jerry Kruger's team at Salt Lake City, where they did look at the phenotyping very, very carefully. And I think that's something we've tended to overlook in the race to looking at genetics and molecular biomarkers and immunology. A lot of the very important data is there in front of us every day when we're running a clinic. It's how the clinical appearance of those patients. And I think the thin plaque work is a good example of that. He was able to differentiate the different plant types. And I think the IPC several years ago came up with a classification, a phenotypic classification, which still holds some water, I think, about the clinical phenotypes. And obviously we had pustular psoriasis separated even then, I think, but there's small plaque, large plaque, etc. And those are telling us something. And I remember several years ago now, I had a medical student who worked with me one summer in our psoriasis clinic in Manchester, and his sole job was to map every single patient with their different forms of their chronic plaque psoriasis and map it out. And he reckoned at the end of that summer, he could recognize within chronic plaque 10 different patterns of disease. Now, we never took it forward, but those could, that's some important information there. Just one other point, just before I go to Catherine, is that, there are patients who have just a few, we see this, they have these, no matter how well they've done with a biologic, they've got a few recalcitrant plaques, usually on the lower leg, and why is it that those stay? So that's also another sort of marker. I don't know why, but Catherine.
Oh, I agree. And Andy, I mean, you say TRMs are associated with severity. What was your marker of there? The number of TRMs related to disease severity. Was that based on PASI or target?
It's PASI. But it is in the recurrence of disease, it is my experience too, that it comes back on the shins or the scalp.
Yeah. And well, I mean, we know, and I mean, we know even with the really effective biologics, there are sites that don't clear. So aquial psoriasis typically doesn't clear, lower legs as well. So I agree, there's sort of different phenotypes, which probably does indicate, underlying maybe different mechanisms, maybe different drug exposure as well.
I guess what I'm saying, if we have early disease trials going forward, as we've been discussing, there could be early disease that's thick. right? And then early disease that is not as well established. And maybe that's why we see some differences in the literature about disease duration, because maybe it's not about the duration, but the thickness of the lesion.
Yeah, well, I think that, Andy, though, it's about getting the understanding the duration, because if you do it from when they had the diagnosis of psoriasis, well, actually, as we were talking about earlier, there's these premonitory signs which may have been going on for a little while. So actually, they've actually had psoriasis for maybe several years, and maybe it's how we can recognize those very early changes, which means that you can get in and make a difference.
So I do want to encourage other audience members to join our discussion. If people bring a mic, I think Mahira has a question in the front. I will ask one from the Zoom. Wayne Gulliver from Canada, Newfoundland, Canada, wants to know about sex. And so he's curious about his hypothesis that women tend to be more recalcitrant to treatment than men. Some data we published a long time ago shows that disease onset seems to occur earlier in girls. If you look at the prevalence of psoriasis by age, the prevalence starts going up in young girls first before boys, and then sort of becomes similar in later adolescence. So do we need to think about this question of early treatment differently by sex?
Well, that was partly answered to some extent by the Stockholm cohort study, where they showed that the severity of disease, more severe disease, is if you're a male. But I agree that women are, in all the studies we've done in Badbeer, they outcome the chances of getting a good response and a long-term durable response to a biologic is less.
And interestingly, when we stratified for the HLA positive or negative CO602, we found that this association between negative status and adiposity and BMI, waist circumference and cardiometabolic was actually more marked in women than it was in men. So there seemed to be quite a different sex difference, and actually that might explain some of the so I mean, I think Wayne has brought up an incredibly important point, because that stratification around sex and and in the genetics and so on, it hasn't really been properly looked at in a systematic way, and I think it needs to be.
Yeah, I agree. Okay, Mahira.
Yeah, Chris, I have two questions, or to Catherine as well. In a perfect world, if I had a systemic or a biologic available and cheap, you are telling me that if I get a patient with a couple of plaques, it's advisable to give him systemic therapy, and when and why? And when shall I stop? I mean, I gave him systemic therapy, biologic for a couple of months, and he cleared. What do I do then? This is one question. The other one, you've mentioned people who are, I'm discovering psoriasis subclinically for any reason. A family who are, for example, genetically predisposed or whatever. What am I going to do with them? Do I give them proactive treatment? Do I tell them lifestyle management? Do I say what to avoid? Do I say triggers, and what do I do? And thanks.
Well, shall I start? So I deliberately, this was a provocative statement at the end, because I wanted to make people think in that way, and that that the skin, all of the skin is not normal in patients with psoriasis. It's not just those few plaques that we can see. The immune profile of the skin has already changed. And I showed you just that data from Langerhans cells, but I'm sure there's a lot of other things going on if you interrogated that. So you could make the point, if you're serious about managing psoriasis and maybe trying to switch it off, that you do treat very early on, not because they've just got extensive disease, but they've already got a few plaques. Now, if that's successful, then you could, maybe we're aiming for a cure. That would be a great discussion, a great sort of think tank discussion as well. Can we cure psoriasis? But I think that if you could get in there early, the idea is to switch it off, and therefore you'd stop treatment. And that's maybe we're going to see something along those lines with the high dose
risankizumab or something. Yeah, maybe one of the conventional therapies. Yeah.
And then with the if you're going to screen for something, you've got to be able to do something about it.
Yeah.
And
sorry.
And I was just going to say, so before I hand over to Catherine, just to say that going to screen for something, then I think lifestyle advice is going to be very important in those individuals when we know that gaining weight or whatever else could well be a trigger. Catherine.
Yeah.
Well, I mean, I think Mahira, if you have somebody at risk of psoriasis, the most important intervention is to tell them not to get fat, because we know that psoriasis is obesity is causally related to psoriasis. So, and estimates from studies suggest that 25% of psoriasis is completely avoidable if people maintained a healthy BMI. So I would say, I would agree with Chris that lifestyle, what do we actually know and what have we got good evidence for now? And that is, there's a lot we can do in terms of lifestyle modification and keeping healthy. So I think that's the first thing. And personally, I do feel that we need to really better understand the natural history and trajectories of the psoriasis subsets who are going to go on and develop disease that's a problem for them and comorbidities before we start advocating for early intervention with biologics, because we a lot of patients with psoriasis, first of all, they get one patch of psoriasis and it goes away and it never comes back again. We're going to be treating a lot of people who don't need treatment.
Well, you're right, and this is why I put it out there. I guess the other way I could argue this, of course, is if you believe in neuroinflammation in people with psoriasis, then they may actually be the neuroinflammation, which can occur even with mild disease, with limited disease, might be managed as well. So in changing their outlook on life. But just one other point about natural history, which I think is a really important one, is that we know very little about what happens to psoriasis as people move through life. Does it improve when they get older, or does it get worse, or does it go away? Because the thing is that if the patient's doing fine, they don't come back and see us.
Yeah, we have some prevalence data. The prevalence disease seems to go down in older individuals, and could that be a mortality effect or a senescence effect? Is hard to know for certain. I suspect some of it's senescence. I want to flip the script a little bit. Could we do harm by treating too early, or by choosing the wrong therapy, not choosing the right therapy first? And the hypothesis behind this might be that we know that patients in clinical trials who may have been on multiple biologics beforehand and multiple prior treatments, they seem to often be more resistant to therapies. So is there a possibility that when we treat this disease, that we may make them immunologically less responsive or more difficult to manage over time? Why don't we start with Catherine and we'll go to Chris. We'll flip since I'm flipping the script, we'll flip the order.
No, I agree with you, Joel. Though I think we don't know. We don't know. And actually, I'd respond to your. You called for us to start doing pragmatic trials. We could actually be very nimble with our registries and just have a point of care randomization to one or other biologic, very simply, and we could start to ask some of the, address some of these questions really quite easily. So I think that's exactly my point, that one doesn't know the unintended consequences, collateral damage.
I have to agree. I mean, that's why we were, as an organization, IPC, were very proactive about encouraging admission of children who are starting biologics into registries, and not just biologics, systemic therapies, because intervening early, and that is a way of intervening early, but changing the immune profile, and of course those patients we're seeing very early on in the disease, their immune profile is different than the average patient we'd see in our psoriasis clinic. So there's things that we're doing to their immune responses which may not be manifesting as clinically as sort of increased infection and everything else, but there may be changes which we're heading, 20, 30, 40 years down the line, there may be problems. Yeah. And that's why the registries are so important.
So I think, UK has certainly been a major leader in these sort of pragmatic random point of care randomization. I mean, the COVID era is a perfect example of that. How your health system was first to discover dexamethasone, and that worked, and then demonstrate other therapies that don't work. In the US, we have a chance of doing some of this work too. We have some large integrated health systems like a Kaiser, for example. They purchase these drugs anyway, that they certainly can decide to do a randomized point of care study. So I think there's an opportunity here, and maybe the IPC could be leaders in this area of calling for how to do this and why it's necessary. I want to see if we have any more questions from the audience. We have a hand up, and someone could bring a microphone over, and if you could just introduce yourself.
Hi, Albert Duvetorp from Sweden. I have a question about recalcitrant plaques or difficult to treat plaques, because I've often observed the same as you, that you have patients may have specific plaques that don't respond to treatment. Would you say these are plaques that have been there longer, like the first plaque that when a patient develop disease? Would that be the same plaque that is difficult to treat later on?
Well, it's a very good question. I guess that in the scalp, that might be the case, but my view is that they probably aren't necessarily the first ones to appear. They just seem to have this recalcitrance, and it may well be to maybe the accumulation of TRMs in those specific sites. I don't think we know, but I don't think it relates to the sort of the appearance of the order of appearance is the order of they disappearance, so to speak. You know, they come in first, they disappear last. I don't think that's necessarily the case.
I think yeah, there's a
Catherine
little bit of
thinks.
work. So another way to think about this question is the person who has one plaque left after having extensive disease, and histologically and transcriptomically, it's still psoriasis, right? It's still the same disease, and so why that one plaque doesn't respond is not well identified. So, any other questions we have? Oh, Catherine, do you want to chime in?
No, I agree. Although the only other thing I'd say is, some of it might be to do with drug, the persistent or remaining plaques can respond to an increased dose of drugs. So some of it might be inadequate drug exposure for whatever reason. So, we all know that if you escalate the dose of drug, you do sometimes push the response. But I agree that those very recalcitrant plaques can be very, very resistant. I have nothing else to say. Yeah.